Hello, and thank you for joining us for what I hope will be an interesting and informative discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from the Griffith University in Brisbane, Queensland, Australia. And today I'm delighted to be joined by the Professor of Infectious Diseases, Public Health, Preventative Medicine, Ophthalmology from the Oregon Health and Science University of the USA. He's also a steering committee member of CSF, Professor Kevin Winthrop. Welcome, Kevin, and thank you so much for giving up your time. We greatly appreciate it.
Yeah, thanks, Peter. Great to see you and great to talk with you again.
Okay, so we are talking about a recent paper that you published in the Annals of Rheumatic Diseases, and it's a paper that's looking at a fairly practical and common clinical issue now, and that is the most recent data on the incidence and risk factors of Zoster in patients in RA who are receiving upadacitinib. We were talking in a prior podcast about the FDA decision, the JAK market, and how it's been affected by oral surveillance. UPA at the 15 milligram dose is about the last JAK standing in the US at a decent dose. What's the market like for JAKs in the US at the moment? Very commonly used here in the monotherapy market.
Yeah, I mean, obviously the goal is to be the last JAK standing, Peter. So
then you hit the jackpot. Huh?
Yeah, maybe UPA's doing that. I don't know. I mean, I obviously Barry being at a lower, a less than ideal therapeutic dose, there hasn't been a lot of Barry use here in the U.S. So I think there has been a lot of uptake of UPA. I think the oral surveillance data may be slowing that down, and I certainly think practicing rheumatologists in wake of the FDA label change are looking at who they have on JAKs now, but particularly new patients coming in and thinking about maybe using it in younger individuals or people who are lacking some of the comorbidities that we're seeing in the oral surveillance data. So I do think it's affecting practice. I know my GI friends who are all using TOFA at 10 milligrams are freaking out about it because that's the dose they use, and that's the dose where most of the risk from oral surveillance was really seen at. So that's that.
So how did you do the study? Tell us about the SELECT program.
Sure. This was fun to do. I mean, it is the RA clinical trial program or development program for UPA. Took place over many years. And this was just looking basically at all the phase 3 data. I think there were 6 phase 3 trials, if I remember right. All collapsed, and it included people on methotrexate alone and a direct comparator with adalimumab plus methotrexate. And then there were 2 UPA doses, the 15, which was approved, and the 30, which had a real high rate of adverse events, a number of different adverse events. So the risk benefit wasn't there for 30, and so it did not go forward. So 15 was the one that went forward. And so the nice thing about this analysis is that there's a decent amount of person years of exposure, and we did have a lot of person years of exposure at those comparator groups, which was nice. And we're able to look at rates over the long term of the usual, the AESIs, adverse events of special interest.
Okay, and you did see a nice dose response for Zoster anyway, didn't you?
Yeah, I mean, opportunistic infection, serious infection, Zoster. Yeah, I mean, the 30 milligram hit it out of the park pretty much on all those. But whereas the 15 milligram was, so for Zoster, it behaved like we thought it would. It was, 2 to 3-fold higher than what we saw with methotrexate or adalimumab. For serious infection, it also performed how we would think it would. It actually similar to what was seen in oral surveillance and every other JAK analysis. It looked just like the TNF blocker. The rates were around 3 or 2.5 per 100 patient years, and kind of came in there just like all the other JAKs and the TNF blockers. So it looked very similar with serious infection. And maybe some of these other outcomes we can talk about as well. But the Zoster really hit the mark, and the 30 again was really quite high. I think it was 5 times higher in the 30 group as compared to adalimumab. So no one was excited.
And very few people vaccinated in this study.
Yeah, I think vaccine history was collected as best it could. I'm sure it was under-collected, underreported, but what we found was, yes, a very low percent that had been vaccinated, or at least that's what we recognized. So,
what's the vax rate like in the US? And can you just explain for the audience the difference between Zostavax and Shingrix?
Yeah, so Zostavax is still being used in quite a few places around the world. Shingrix is still, not on the market in a number of countries. Zostavax, of course, is the live vaccine. Shingrix is a subunit, not non-live vaccine, highly rejuvenated. Zostavax works. It provides probably a couple of years of immunity. Jeff Curtis and I just published a study where we actually had given, 617 people Zostavax versus placebo. And these were patients on TNF blockers with methotrexate and or prednisone. And not one of them had any, shingles from the vaccine at all. So we proved that it was safe to go ahead and give people on at least TNF blockers, methotrexate, and prednisone. So there are places in the world where that's kind of a nice bridging strategy to, vaccinate someone now and then, wait till you get access to Shingrix. In the parts of the world where we've got Shingrix, there's still very little data. We're doing a large study looking at the safety and immunogenicity of the vaccine and efficacy of the vaccine in patients who are on JAKs and who are on TNF blockers. So that, I'll have some more definitive data for you in a year or two. But for right now, you can expect that it will provide some level of protection, probably to a greater extent than Zostavax. I think you can use it. I do know people are using it. I don't know what our coverage in the US is. I mean, like 4 or 5 years ago or something like that, 6 years ago, when Jeff and I started getting into this because of all the JAKs, we did some population-based work and it was really low. It was like 4% of RA patients had been vaccinated. So I know it's much higher now, but I doubt it's north of 20%. I think it's still a huge unmet need. So, but I could be wrong, but it's definitely not the majority of patients.
Do you get any feel that the vax can flare rheumatoid, which is one of the concerns of the rheumatology community?
Yeah, I actually had a patient today where that happened. It definitely happens. The best analysis was published at a Cleveland clinic, and there's been a couple like kind of open label looks at that or just observational study looks at that. And really the one that looked most closely was this Cleveland Clinic analyses. And they did see an increased flare, particularly with people with inflammatory arthritides. And it was mainly linked to people who had higher disease activity at baseline or at the time of vaccination. So I do, and that makes sense, right? If they're more in remission or an LDA, they're less likely to have a flare. So I think people with stable disease, it's probably unexpected to get a flare, but you do see this increased risk, particularly people who are a bit more active at baseline.
Mind you, I'm seeing all these people flaring after their COVID vax too. About 7 to 10 days later, I've seen RA, PSA, lupus, DMR, and on Monday, a new giant cell arteritis 7 days after a COVID vax. Coincidence or who knows?
Yeah, I mean, from where that's been reported, the rates of flare seem probably not above baseline. It's hard for me to believe because I'm a guy who had his gout flare after his first vaccine. but I suspect there is a small increased risk of flare, but it's manageable. And
it has to be done.
Yeah.
So tell us the risk factors for Zoster from this study.
Yeah, the cool thing about this analysis, I think, and the reason why I hopefully convinced ARD to publish it was the first multivariate analysis of this question in JAKs that looked at the history of Zoster as a risk factor. We didn't do that with TOFA. We didn't do that with Berry, if I recall. I just don't think we had that data. And in this program, it was collected at time of entry to the studies. And it turned out to be the strongest risk factor for getting Zoster. I mean, that and being in Asia, which we already knew is a risk factor with JAKs from all the other programs. So, it's counterintuitive. I think I was saying before that if you have an episode of shingles, you should be boosting your immunity. You should be essentially vaccinating yourself and protecting yourself from future episodes. But there is this group of people in these JAK development programs where that doesn't occur. They actually have recurrent Zoster. It's about 3 or 4% in each program where you see this. So there's definitely a group of people that behave different than the general population where if you have an episode of shingles, you really are very unlikely to have another one in your lifetime. So there's something, I mean, my personal opinion is there's probably several ways to get shingles. There's a deficiency in NK cells, or there's a deficiency in your, CD4, cell-mediated immunity. And in other cases, maybe it's just simply a JAK signaling defect, an interferon signaling defect, very locally that causes it. So I think there's probably different reasons why some of these patients develop shingles and some don't in these programs. So I would love to get my hands on these people with recurrent zoster. There's got to be, that's a nice group to study and do some sort of nested case control analysis, comparing them. They must just behave differently. So, we're doing this big vaccine study I mentioned to you. So we're hopefully, we're going to be giving people on JAK, Shingrix, and we're hopefully going to see, we'll find out if there's some group of people that has a differential immune response to the vaccine or not.
Have you got a hypothesis for the Asian risk?
I do have several hypotheses. So there was a genetic look at that some SNPs that were overrepresented in that region that might explain just a tiny bit of that increased risk, maybe like 12 or 15% of it. I think there's also probably a differential detection there as compared to other places in the world. I think probably people are more likely to report it and see it and go to the doctor or nurse to go get it evaluated. I also think that it might be a body weight issue, that there is greater bioavailability and therefore activity of some of the JAK inhibitors in smaller individuals, less weighted individuals. And I think that may, they're essentially having a more effective or higher dose effectively. And so that may explain some of the higher risk too. And we modeled that a few times. And I remember one model with TOFA, that was definitely there. It wasn't BMI, it was weight. So it made me always think that this could be an issue with some of the other JAKs. And I think we modeled that in this one. We modeled BMI, if I remember right. So BMI is probably not the right thing to model. It's probably weight if you want to explore that idea.
Yeah, that's actually, we'll have to go back to Select Sunrise and see what the 7.5 milligram dose had as far as zoster rate, but probably the numbers are too small. You published a lovely paper with TOFA. If you take away methotrexate and prednisone, you drop the risk significantly. Barry didn't seem to fit that model very as well. And with UPA, steroids didn't seem to make a difference. What's your thoughts about concomitant conventional DMARDs and background prednisone, which didn't seem to be a risk here?
Yeah, it's interesting, Peter. I mean, so with the TOFA data, eventually with maturation of that data and more statistical power, we were able to separate out the effects of steroids from methotrexate. And it looked like the methotrexate really wasn't a bad actor and wasn't really contributing independently. But we did see this residual, very strong independent risk with steroids, no question. And that is odd with this analysis. In the multivariate analysis, we just simply did not see that as a risk factor with UPA. And I can't explain why, other than, as an epidemiologist, when I see these things, I wonder if there's no additive risk because patients are already at such a high risk due to other factors like being in Asia or being on a JAK inhibitor that you're just not seeing additional risk with other known risk factors. But that would just be a guess. I really, in my heart of heart, believe that steroids increase the risk of zoster simply because we've seen it in so many studies, and it makes sense, physiologically. So, but interesting, we just didn't see it here. So,
and the other thing that was surprised to me, that of the patients who had zoster during a UPA trial, 6% and 9% at the 15 and the 30 had a recurrent attack of zoster in the follow-up time, usually after 1 to 2 years. That would be most unusual, wouldn't it?
Yeah, this kind of gets to what I was saying before. I mean, that group of people with recurrent zoster, something different about them. They should be building their immunity and protecting themselves from additional episodes, but that's not what's happening with that group. So Very interesting. And, just back to your last question too, I mean, if you look at our multivariate analysis, we know that age is a risk factor, right? But if you look at age in the multivariate analysis, it wasn't even it was a risk factor for the 15 milligram dose, but it wasn't for the 30. The
Right.
greater than 65 versus less than 50 wasn't even a risk if you were on 30. And my interpretation that would be similar to what I just told you, is that they were all at such high risk on 30 that the age really didn't matter. So I mean, that's kind of how I wonder about, the steroid question. Yeah, maybe there's just not enough additional risk to add when you're already at a high enough level. I don't know. That would be my guess.
So for the practicing clinician, what do you recommend as Zoster management in RA starting a JAK? And what do you do with COVID vax people on a JAK?
Yeah, I mean, obviously the lowest dose possible. So with UPA, I mean, you only have 15 milligrams, so that's easy. And I do recommend trying to get rid of prednisone if you can. And then, vaccination, either if they're already on the JAK, I would vaccinate them with Shingrix or send them to us for our study, because that's what we're going to do. I mean, the question is, and it's important we do the study because we have to know how well this vaccine works in this setting, because it may be that people need boosters, right? I mean, this is what we're seeing with COVID vaccine. Certain groups of people are definitely not getting the types of responses we want them to have, and they do need boosters. So we got to figure that out with Shingrix. I guess one question would be, should you be holding the JAK inhibitor at the time of vaccination? We certainly have toyed around that issue with the COVID vaccines. I mean, some people are doing that here. I don't know about you guys. Is that something people are doing, or?
Well, only because the ACR has recommended you stop a JAK for 5 days, and it's very hard to fly in the face of that kind of recommendation.
Yeah. I mean, it's a guess based on what we've seen in some other studies. We're doing a study where we're actually experimentally doing that to see if it makes a difference. And there's other people doing that same study, I think. So I think we'll have an answer. I suspect it will help if you stop a JAK for probably 2 weeks. I'm not sure. I just think 1 week might help, but 2 weeks would probably be better based on all the data I know. But
yeah, it's
whether
tricky
it makes
to
a
even
difference clinically, though, that's another question.
Yeah. It's tricky to even know what the antibody levels mean. Is there a level you have to reach to be protected, or has it got nothing to do with level?
Right. So that's the money question, right? Even if you drop levels by 50%, doesn't even matter, because maybe you're all still above the protective level anyway, or maybe you're all below the protective level anyway, and it doesn't matter. So, I mean, that, it's interesting. The couple Zostavax trials we did in people, pre-starting TOFA, I mean, we did not see, they were small trials. They weren't powered to look at efficacy, but the rates that we saw in the trial I did and the other trial that was published, I was not involved with, but in both experiences, I mean, we didn't see any hint of protection. So it's interesting. I mean, Shingrix is a more robust vaccine and should offer greater protection, but we'll have to see what the studies show.
Okay, thank you so much. The JAKs are here to stay. We've got to learn how to manage them better, particularly in the monotherapy market. We can't get tocilizumab for love or money here because it's all being used for COVID. Yeah. And we won't get a new supply till next February, March. And we haven't got sarilumab, so we need a monotherapy agent because that's up to a third of our patients. So we've got to learn how to use them well. A take-home message from your Zoster study?
Yeah, I think the take-home would be, expect Zoster. It's likely to occur, at least, in someone who's been on drug for a few years. But if they have other risk factors, if they've had Zoster before, they're more at risk, which again is counterintuitive, but that's the deal. And I think that just is a recognition of people who are, immunosuppressed, or at least immunosuppressed in some particular pathway or way that allows them to have Zoster again. So, I mean, I think, there's not much you can do other than, there's no tests, there's no real screening for who's at risk. So I think, vaccinating before JAK start is ideal. If all you have is Zostavax, use it. If you have Shingrix, I'd use that preferentially. And if they're already on a JAK, I would just go ahead and give them Shingrix. Whether you stop the JAK or not, I don't know if that's necessary. I suspect it's probably not necessary, but I'll have an answer for you in a year or two on that one.
So thanks again, Kevin, for your time. We greatly appreciate it. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can get detailed slide sets available in the publications section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or other podcast media and give us some feedback and let us know what you think. Thank you so much, Kevin, for your time and trouble. We appreciate it.
Thank you, Peter. Take care. Happy holidays.
All the best.